This week on the BackTable podcast.
So we do a lot of deep venous arterialization for these patients. So we have patients who've had diabetes for so many years. They have the combination of micro and macrovascular disease. They have medial artery calcinosis. These patients just have an incredibly high risk of limb loss and amputation. And unfortunately, the standard way of treating them, whether surgically or with endovascular means, just cannot address such diffuse disease of these small vessels. So then deep venous arterialization becomes an option for them, where we can connect one artery to one vein, then deliver oxygen to blood to the foot, trying to help them save the limbs. So we participated in the PROMISE 2 clinical trial, which was released in New England Journal of Medicine, and 66% amputation-free survival. So we're hoping we get to do more and more of that, trying to help these patients.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of the podcast on iTunes, Spotify, or backtable.com. Subscribe to the podcast, leave us a review, or reach out to us on Twitter or email to let us know how we can make this a more valuable resource for the endovascular community. First, a brief word from our sponsors.
Want to save time when you order medical devices for your lab? Restock Boston Scientific products seamlessly with Lab Agent, an easy, time-saving device. This free solution allows any user to quickly scan and reorder a Boston Scientific product with a handheld device. Then it arrives with free 2-day shipping. Users have saved up to 5 hours a week. Visit bostonscientific.com/labagent to learn more about Lab Agent today. That's Lab Agent from Boston Scientific.
Physicians worldwide rely on peripheral catheters by Reflow Medical, and now Reflow is introducing Cora catheters, a unique line of coronary catheters that are setting a new standard for complex PCI. The CoraFlex, CoraForce, and the CoraCross are all engineered with groundbreaking technology, and each device offers unmatched bilateral torque with the lowest overall profile available. For more information, visit www.reflowmedical.com. Now, back to the show. Today I'm joined by Dr. Zola N'Dandu in Kenner, Louisiana, to talk about building a CLI team. Zola, thanks for joining us.
Thank you very much for having me today. This is excellent.
So where are you working?
So I work at Ochsner Medical Center at one of the few campuses we have here in Louisiana, particularly at the one that in Kenner, close to the airport.
Right on. Is it primarily hospital setting or outpatient? Or?
It's primarily a hospital setting. We have a collaboration with a big system as well. So we do have residents and fellows that work with us as well.
Nice. Okay, cool. And so, for our listeners, Zola is an interventional cardiologist. Can you tell us a little bit about your practice?
Yes, as you said, I'm an interventional cardiologist. My practice, I'll say probably between 60 to 65% is peripheral, mostly critical limb ischemia. And then I also still do some general cardiology and interventional cardiology as well. But the focus really is with PAD and venous disease.
Yeah, most of us who follow you on Twitter have seen, a lot of the stuff you're doing, and it's a great opportunity for the residents and fellows. How long have you been there?
So I've been within the Ochsner system altogether for 22 years. That includes my 8 years of training. I did internal medicine, general cardiology, and interventional cardiology here, including an extra year for peripheral training. And then altogether, after my training, I've been here the whole time working, except for 2 years that was spent in Phoenix, Arizona. So altogether, about 22 years.
So that's cool. You did a full year dedicated to peripheral work. That's awesome.
That's correct.
So I did my surgery internship at Ochsner, so I know the place fairly well. What I'm curious about is when you were in training, were you guys seeing the volume of, not only just routine peripheral work, but critical limb ischemia that you're seeing now?
Not as much. We did a lot of work with really extensive with peripheral arterial disease that included carotid, subclavians, iliac disease, femoral popliteal as well. We did some infrapopliteal and inframalleolar disease, but not as much. I think the reason why I'm doing a lot of it now is just because it's become my niche and my focus, but not as much. So those are things that I had to seek also outside after my training, traveling, going to conferences, and then connecting with people in the field.
Okay. So what made you decide to grow this part of your practice and ultimately develop a dedicated CLI team?
Yeah, so I remember going to a conference in Las Vegas, Viva, one of the conferences there. And I remember sitting in the audience, and I was watching a live case. I was being performed by Andre Schmitz in Leipzig, Germany. I was just mesmerized by the work that was being done. At that time, I was already doing some peripheral work. but I saw the dedication that was given to addressing infrapopliteal and inframalleolar disease. And I think that was really the trigger for me. And then when I came back here at Ochsner Kenner, we have a wound care center, and I saw these patients, and I wanted to make sure I could be of help. And so that's how the whole thing came together after several years.
So once you decided to kick this off, where do you even start, building a team from scratch?
Yeah, it's definitely challenging. So I think what worked for us is I wanted to make sure that I could be that champion, that I could show the enthusiasm. So I started basically everything on my own in a sense. So I would take care of those patients. I'll follow them. I had an Excel spreadsheet where I made sure they had the follow-up visits. I was doing everything on my own. I'll call the podiatrist or the surgeon that was doing the wound care, just trying to find a way to keep up with these folks. But then as time went on, we had podiatrists that could see the work that was being done. And then we had a couple of infectious disease doctors that we worked very closely with. We made sure all of our patients went to them. And before we knew it, we had this group of physicians that were taking care of these patients. And all of us at some point in time said, look, we can do actually a better job if we just kind of make it a point to making sure we're holding hands all the time so we can take care of these patients. And that's how the whole program grew. And then other partners joined because it's not possible to do this by yourself. And so having that team has really made a big difference. And now I see patients in wound care every other week. And my wound care team, home health nurses, they call me on my cell phone. We're constantly communicating.
That's awesome.
To make sure we get to take care of these complex patients.
Tell me a little bit about your working relationship with the other doctors involved, podiatry, surgery. I would imagine, correct me if I'm wrong, that this was a really valuable addition to them because, these are a really challenging subset of PAD patients, right? Especially for them.
That's correct. So they have a lot of issues, as you mentioned, a lot of comorbidities. So I think when people saw the commitment on my part, I think it helped everybody to get involved because I'm sure other people probably thought about doing this before, but perhaps they found themselves doing it by themselves, which can become extremely challenging. But when you know that there are other players involved in the sandbox, then it's also become easier, right? Because you can bring the highest level of expertise, but if there are other things that you cannot do, that there's somebody else that'll take care of that for overall good outcomes.
Right on. So how are you guys identifying most of these patients? Just from Twitter alone, it seems like you're pretty busy with this. You've got a lot of these patients that you've been treating. How do they get to you?
So they come to us from multiple sources. Some of them will come to us from podiatrists. Some of them will come to us from hospitalists. And some of them will come from endocrinologists. And some people, by word of mouth, have heard about the work that we do, will come to us for second opinion. Some will come to us from infectious disease physicians as well. And so with all the teaching that we do in the outreach, podiatrists, residents, internal medicine family practice residents, cardiology fellows have also become our extension. So wherever they are, when they meet people who are in trouble, they reach out to us. So we get referrals from literally every corner to come and see us and we take care of them.
Tell me how else the team has evolved. It started out with you on a laptop with an Excel spreadsheet. How's it gone from there to where you are today?
Yeah, so where we are today, we have a nurse coordinator, two of them. One who's housed in wound care, and the other is housed in our cardiology clinic. And
is that strictly for CLI stuff, or is that for all PAD?
So the one that's in our clinic is for all PAD, and then the one that's in wound care is for all of our wound patients. So that's patients with PAD, but also patients with venous ulcers. And those nurses are in constant communication, the two of them, and also with us, the physicians, and with the patients and their families. And so we make sure that they have all the follow-ups. We make sure we plug them in our smoking cessation for those that are smoking. We follow them closely. We make sure they see the endocrinologists. One of our endocrinologists has an NIH-funded grant to take care of diabetic patients with CLTI. And so those nurses really have made a big difference. One of the challenges we used to face at times, Mike, was a patient will come to the hospital. We'll work on them. The patient will get discharged to a rehab facility or a skilled nurse facility. And sometime from then on, they would get lost to discharge. So these nurses, they talk with those patients weekly. They talk with the families. And soon after they get discharged, they come and see us. Or sometime even while they're there, we can make an exception where we can bring him and see him in office. So it's really has helped us tremendously, because otherwise, early on we could, when we didn't have as many patients. But now that the practice has grown, it will be very difficult to do on our own.
I bet. And so for most of these patients, are they getting seen by the other doctors on your team as well? Or, they come to you, have a procedure, and then follow up with everyone? How does that work? I mean, these are challenging patients who have lots of issues.
Yes, absolutely. So that's a phenomenal question. There's some research actually I've just presented recently at the New Cardiovascular Horizon, and I mentioned on the average, after a patient has a vascular procedure for CLTI, in the coming months, those patients have up to average of 16.3 visits. So it's not easy for the patients, for the families. You can imagine the co-pays and all those things. So among the things that we've done, one of them is I'm in wound care every other Tuesday. So when a patient comes to wound care, I'll see them as a vascular specialist. The podiatrist sees them, and then also the wound care nurse. And all of us are in the room together. So we address the blood pressure, address the medication, make sure from a vascular standpoint things are okay. The podiatrist will address the wound. And if we need to come up with follow-ups, home health orders, ultrasounds, ABIs, all those kind of things, the nurse, everything in writing. As the patient's leaving the room, everything is ordered. When they go home, everything is all set. And when they come back 2 weeks later, I'm seeing them as well. So doing that has helped tremendously, because that's easily 3 visits there that we've been able to eliminate in one.
16, that's crazy. And also not surprising, I mean, these are really complex patients and they're really complex treatments. This is fantastic for your residents and fellows. I mean, you did a whole year in extra PAD training. You could spend a whole year just doing infrapopliteal work, not to mention, you said inframalleolar work. And so that's awesome for them. Has this become a really large part of your practice, CLTI?
Yes. On the average, when I'm in clinic, probably if I have, 20, 22 patients, probably half of them are coming for these reasons. Some of them are coming, as new patients needing something done. Some are coming for the follow-ups. And so it's become a huge part of our practice. But, it's something I really enjoy, so it makes it easier that way.
So the patients that are coming in to see for the first time, like what imaging do they usually come in with? I mean, is it standardized or is it different for every patient?
There's a component, I'll say it's standardized, but, I think our patient, even though there are a lot of them, even though they have a lot of similarities, but they're also unique in their own way. So we're trying to make sure if they're going to come for the first time we want to make sure they have studies prior to. So if they're coming for a wound that looks arterial, we're going to have an ankle breaker index, a toe breaker indices. Some of our patients have, falsely abnormal ABIs. We have an ultrasound, we have labs, and then they'll come in. And then from there, we'll evaluate them and we'll determine what do they need in collaboration with podiatrists and wound care team. For patients that are coming to us for the first time, but they're coming for a second opinion, most of the folks have some studies with them. They've had ABIs, TBIs, labs, probably had an angiogram, or probably had an unsuccessful procedure, or they had a procedure, somebody said they needed amputation. So they usually have all that information. We're trying to get that beforehand. I like to usually review those studies before they arrive. So that way, when I'm meeting them, I can at least during that visit tell them what can we do to help them. So, and then take it from there.
Do you order your own studies on these patients? Do you ever get like CT angiograms, or do you just kind of wait and evaluate it with an angio?
Sometimes we do CT angiogram. I find it to be a bit challenging for infrapopliteal, inframalleolar vessels. I think it works very well for the large vessels. And then when they're calcified, and I'm sure you deal with this all the time, because when we order them, you have to read them for us. And
they're all calcified.
Exactly.
I can't. Once you get below the knee, I have a really hard time determining if an artery is even patent or not, even when they get the delays, I can't imagine for the inframalleolar stuff.
I think it's very, very difficult with the CT. So we end up doing angiograms of those folks, and that way we can have very good information and be able to treat them, because, in this space, the foot is the end organ. And not uncommonly, sometimes we don't do a very good job of doing very good angiogram of the inframalleolar vessels. And so without that, unfortunately, we cannot deliver a good therapy. So having a good diagnostic angiogram becomes extremely important in the management of these patients.
No, it's a really good point about, failing to get a good look at the arteries below the ankle. I started with CTA when I was in training. Nobody was treating these, the stuff that you're doing now. And so I didn't even pay attention to, any of the arteries below the ankle. And still, that's like my template when I read one of these. Is it patent to the ankle? Is it patent to the foot? No one's talking about the toes on those studies. Well, let's talk just for a minute about how you're treating them, because, I know you guys are doing some pretty advanced work. And, from a technical standpoint, it seems like this has really evolved in the last 5-10 years, right? So, well, tell us, first of all, what has changed in the treatment of CLTI really in the last, decade?
I think two things. So from a medical standpoint, I think what's changed is we have more medications for our patients, and we have more information about what works, what doesn't work. And then also we know that we can do a much better job to make sure we have patients on guideline-directed medical therapy for PAD. We still have a lot of patients who are not on intense statin therapy with LDL less than 70, on aspirin, on ACE and ARBs, people that can tolerate statin. We don't have them on, PCSK9 and things like that. So having that data really is helpful. We know from the two other trials from Voyager and Compass, the patients will benefit from being on Xarelto. So these are all things, now that we have that ammunition, it becomes extremely important to make sure that all of our patients are treated as such, because we know they do well with those medications. And then from a revascularization standpoint, the surgery is definitely a good option. And for those patients that cannot have surgery, endovascular are a phenomenal option. A lot of these patients have issues that could make it difficult to have surgery, whether because of multiple comorbidities and or not having good veins. And so, but from an endovascular standpoint, there have been tremendous advances in terms of, for instance, things like a radiotorpedo. These are things that we didn't do years ago. We've got so efficient and effective at doing cases with pedal access. And then we have third and fourth generation stents that we did not have before. We have intraproliferative therapy with stents and drug-coated balloons. Now we are working on, bioabsorbable infrapopliteal stents. So there have been tremendous advances in the field. But what we need good data, because we can have all the toys, but if we don't have good data, it makes it very difficult to treat these patients. So we have some trials, but not as many because we are spoiled as cardiologists. If you look at the Acutamide data set for antiplatelet therapy, we have thousands and thousands of patients, and that's not the case with CLTI. So we're getting there. I think we're making good progress, but I think working together becomes extremely important.
What's on the horizon for CLTI, or aside from data, what do we need to see, coming on the horizon that's gonna help these patients and help you do your job?
Yeah, so a couple of things. I think one of them is we still need more ammunition to address infrapopliteal and inframalleolar disease. These are usually long, chronic total occlusions, heavily calcified. How do we address them? Balloon angioplasty works, but unfortunately, it's not good enough. We have recoil, we have dissections. How do we deal with that? The data has not been so good thus far with drug-coated balloons, but I think there were a lot of limitation with the studies. People were not using IVUS and things like that, so we're probably undersizing these balloons. That's why we didn't have good results. And so hopefully, as we continue to get better, we can find more ways of treating infrapopliteal and inframalleolar disease. Like I mentioned earlier, a lot of trials with bioabsorbable stent. The results were not as good in the coroners, but they've been favorable thus far in the peripheral world. So hopefully we get to do that. There's some other technology in development where instead of deploying a stent, we have temporary stents where you put a stent that spikes. You can temporarily help to minimize dissection. Some of those stents also have drug medication that can be released into the endothelium, and then you remove it. And the idea behind that is less restenosis, less dissection, less recoil, keep these vessels open. So it's a stent that's mounted and it has a sheath, and the sheath covers it. So when you unsheath it, you then inflate the balloon. The spikes will go into the vessel. You wait 3 minutes, you deflate the balloon, and then you push that cover to sheath it again to remove it. So there's a clinical trial that we're participating in right now.
That's exciting.
Very much so.
I look forward to reading about that. Well, what else do you want to talk about that I haven't covered on CLTI, building a team, or really anything else you're doing right now that you're excited about?
Sure. The other thing too that we haven't involved with is the treatment of patients that we quote unquote call no option CLTI patient. My hope is we're no longer going to use that nomenclature. So we do a lot of deep venous arterialization for these patients. So we have patients who've had diabetes for so many years. They have the combination of micro and macrovascular disease. They have medial artery calcinosis. These patients just have an incredibly high risk of limb loss and amputation. And unfortunately, the standard way of treating them, whether surgically or with endovascular means, just cannot address such diffuse disease of these small vessels. So then deep venous arterialization becomes an option for them, where we can connect one artery to one vein, then deliver oxygenated blood to the foot, trying to help them save their limbs. So we participated in the PROMISE 2 clinical trial, which was released in New England Journal of Medicine, and 66% amputation-free survival. So we're hoping we get to do more and more of that, trying to help these patients.
Hey, just for a second, a lot of our listeners are trainees. Could you explain how and why that works, deep vein arterialization? It's a kind of a hot topic right now.
So DVA really is a last resort. And the idea behind that is when you connect an artery to a vein, the theory is this particular vein is going to deliver oxygenated blood to the foot and do the reverse of what it's supposed to do, and then deliver oxygenated blood to the capillaries and then return back to the heart. Now, there's a component that's also very interesting. When we see patients with no option, they have low perfusion, whether you do a toe breaker index or tissue oximetry, what we notice is over a period of time, those numbers improve. And even after the conduit is occluded, they maintain the tissue perfusion above the healing threshold. So we think there's a component of angiogenesis that occurs that allows them to recruit more capillaries and collaterals to maintain that perfusion above the healing threshold. So that's how we think it works. But we're still learning. I mean, we still have a long way to go.
Right, it's brand new.
Absolutely.
Very exciting. It seems like somebody probably discovered it on accident.
Mike, what's interesting about DVA is that the very first publication that we have in the literature was published in 1912.
Yeah, it's old.
It's very old.
Somebody was telling me about this.
That's right. So it's old, but we just haven't really had a lot of interest in developing it. But I think now with diabetes, chronic kidney disease, advanced PAD, I think that's where we start thinking about it more, trying to find ways to help these folks. And so hopefully we're going to find a way to fine-tune it and be able to make it a standard treatment.
Certainly, a lot of these no options, quote unquote, no option patients are living a lot longer than they were 30 years ago. And, we're seeing a lot more of these patients who are 30 years ago may not have been alive. Can we talk just for a minute about how you do it?
Sure, absolutely. So the way to do it, the most important thing is really the planning. I think if you're just going to wake up in the morning and go do a case like this, it might not go as well. The pre-planning is extremely important. So first of all, you want a very, very good diagnostic angiogram. You want to make sure if there's any inflow disease that you address that beforehand, so you're not overwhelmed trying to do everything all at once. So we take care of that. Make sure iliac, SFA, POP, all those things are okay. And then if there's going to be an artery, the majority of the time in trials, and even we do off the shelf, we use predominantly the posterior tibial, because the posterior tibial vein and lateral plantar vein are quite large and they can deliver a large amount of blood. So if the patient has an AT and a perineal, you want to definitely maintain those, because the combination of having arterial and the deep venous blood, really, it's helpful. And then the idea behind that is we're going to connect that to a vein. So the posterior tibial artery has two veins next to it. Years ago, when we started doing this, we used to get access in the vein right around the ankle. So we use ultrasound, we get into the vein, we go up, and somewhere mid distal PT or proximal PT, we then make a connection. But when we reverse the access, now you have your wire going downstream, what we noticed was traveling from the ankle and navigating to that plantar loop was extremely difficult because of those valves. And so the one thing that helped us over time was to get access in the plantar vein at the bottom of the foot to ultrasound guidance. That way you're traveling in the same direction with the valves, has made it much, much easier for us. And then regarding crossing, there are multiple ways of crossing. For us that participated in the PROMISE 2 trial, there's a dedicated catheter that has a basket that you put in the venous access, and then a device that's like a re-entry device that punctures into the basket. You advance the 014 wire, you pull the wire to externalize. That's one way. But the lymph flow device is not commercially available thus far. And so we've used the Pioneer catheter, ultrasound guided, as you can see, from artery to vein, and then puncture. Or we've also done it from vein to artery, depending on the circumstances. We've also used the Outback balloon catheter, where you have a balloon inflated into the vein, and then you bring your Outback, you turn it so you can target that balloon and puncture. And once you puncture that balloon, then you advance the wire you know you are in the vein. There's also a device called Bentley catheter. It's also a re-entry device that we've used. And the very last one that we use probably most commonly of all of them is a gun sight technique. That's what we learned from you. You guys use that procedure for your TIPS procedures. And so we do that as well. You put a snare in the vein, a snare in the artery, you line them up, you puncture with a 21 gauge needle with advanced 014 wire, and then we move the needle, pull on both sides to establish connection between the artery and the vein.
Man, that's awesome. So, Zola, once you've made the connection, how do you keep it open?
Great. So the first time we did this, I was fearful that after making that connection, and if I use a balloon to open up the fissure, the patient will start bleeding. Interestingly, they never bleed because blood goes to the place of least resistance. And so it just goes directly into the vein. They never bleed in the soft tissue. So we use a balloon, we open up that fistula. And the other challenge that we have to deal with is to make sure that the valves in the plantar surface are destroyed, so that way blood can go in the opposite direction of what it's supposed to be doing. And so
how do you tell if you got them? How do you tell if you destroyed the valves?
Oh, so we use cutting balloons or scoring balloon. And then what we do is we have a catheter by the ankle and we inject to make sure that we have forward flow going to the forefoot. And that's when we know that we got the valves. And we use IVUS for all these cases, which also helps us to look at those valves to make sure the lumens are open, that we can get blood to the forefoot.
Yeah, I imagine those are kind of tough to interpret. I mean, this is all, none of this is textbook stuff.
That's why I said with that, we're still learning. And then the last part will be putting a cover stent to go from artery into vein all the way down to the ankle. And it closes the fistula so you don't have steel. It also closes all the branches so you don't have any steel all the way down to the ankle, and blood goes to the foot.
How do you follow it up after that? Like, how do you assess the efficacy? I mean, aside from a patient, having flow to the foot, I mean, how do you follow it up?
Very good. So there are a couple of things that we do. Foremost, we make sure physically they're okay. We'll follow them very closely. We do ultrasound. And with that, there are a couple of things that we follow. We want to make sure that the conduit is patent. We check velocities. But what's really important is the flow volume, meaning you can have an open conduit, but if your flow volume is higher than 500 cc per minute, then it's too much blood being stolen out of that, so people don't get much benefit out of that either. And then if your flow also starts dropping less than 200, we start worrying about, is there a stenotic lesion somewhere, either inflow or outflow? So a very low threshold to take those patients back to the cath lab to re-intervene if we need to. So there's that. And then the other thing that we also use is tissue oximetry, where we measure their healing threshold as we follow them. And so not uncommonly, people have single digits, tissue perfusion less than 10, and we can follow them as they're rising through. On the average, from the time that we do a DVA, we want to wait at least 4, maybe 5 weeks before we do any kind of surgery, unless if we need to go do something for infection control and things like that. But if we can wait, the longer we can wait, the better.
Man, that is really exciting stuff. Man, I think that covers most of what I had. Is there anything else that you want to go over that I didn't cover?
No, I think you covered it very well. So if I have to go back and mention a few things, I think when it comes to going back to what we talked about originally, building a CLI team, it takes a group of people who are dedicated wanting to take care of these patients. I think it's doable. I think it's possible. You just have to make sure that you have people with the same mindset or the same mission. And then if you have 2 people or 3 who want to do this, and if they're doing it well, then before you know it, you have the 4th and 6th and 7th that will join. And that's what happened to us. So we have people who are part of our team today who were not either even thinking about this before or not even interested. But I think what we've done has become symbiotic, that they're on board, including our cath lab team. They love doing these cases. Sometimes I struggle when I'm crossing from an integrated approach, and the techs would tell me, hey, is there a way you can just get retrograde access so we can finish this case? But, that wasn't the case 10 years ago. But we're there today because of, we work together and we do this. So there's that component. I think that's really, really important. And then something else that could also help these patients would be the utilization of technology to monitor them. So we do a lot of televisits with these patients where we have a home health nurse at their house. The nurse can take pictures of the wounds, and I can look at them. I can talk with them to make sure things are okay. They can have the outpatient ultrasound at a facility near them. I have the results. I can communicate with them. Just trying to facilitate some of those multiple visits that they have to go through. So I think using artificial intelligence is going to be extremely important. If we can develop some kind of monitor that I can have on their feet to know that the arteries are still open, that would be fantastic. We're not quite there yet, but hopefully we get there.
Not yet. Well, Zola, it's really impressive what you've built, and it's great. We have a challenging patient population in South Louisiana.
Yes.
And hats off to you and your team. And it's just about time for you to open up an office in Baton Rouge.
Okay, very good. Well, we're not that far, so we'll come visit you or come visit us. Our door is always open, lights is on, so please come see us anytime.
I will, man. I'll look you up next time I'm there. But thanks for joining us. We really appreciate it. I learned a lot, and thanks to our listeners.
Thank you very much for having me.
All right.
Bye-bye.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Don,
Michael Barraza,
Jacob Fleming,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.